This next lecture will be divided into two sections. Firstly, we'll discuss the management of a solitary pulmonary nodule. In the second part of the lecture, we're going to touch on interstitial lung diseases. On step 2, the one thing you must be certain of is to know when a biopsy of a solitary pulmonary nodule is appropriate. Let's take a look at some differences between benign appearing lesions and malignant appearing lesions. Firstly, for the benign appearing lesions. In this category, all of the traits listed here will be things that point towards this almost certainly being a benign lesion. In the malignant category, these characteristics absolutely necessitate that a biopsy is taken. That's because while these characteristics do not necessarily mean that the lesion is malignant, they're worrisome enough that biopsy must be done. Nodules in the benign-looking category do not necessarily need to be biopsied. Benign features include being less than 30 years old, whereas greater than 40 is concerning for malignancy. Benign lesions tend to have no change in size over time on serial films. Malignant lesions will tend to be enlarging. Benign lesions are more likely to occur in a non-smoker, whereas malignant lung nodules in a smoker. Smooth borders are often found in a benign solitary pulmonary nodule, whereas a malignant nodule tends to appear more spiculated, which means the edges of the lesion have small spikes. Small lesions, those less than 1 centimeter, are often benign, whereas larger lesions, especially greater than 2 centimeters, tend to be more likely to be malignant. If the patient has normal underlying lung, that of course is going to favor a benign lesion, whereas patients with atelectasis, you're more concerned that there may be a post-obstructive process going on. If there's no lymphadenopathy, again, this is more concerning that the patient has a benign lesion and not a malignant lesion. Presence of adenopathy is certainly concerning for cancer. Lastly, a dense central calcification, in fact, what we often call popcorn-appearing calcification, favors a benign lesion. If you see sparse eccentric calcification, you're going to be more concerned about a malignant lesion. The PET scan is a separate issue that we'll discuss in the future, but for now, just be aware that the PET scan is normal in benign lesions and abnormal in malignant lesions. One important tip to keep in mind is that the best initial step with all solitary lung lesions is to compare the size of the lesion with that on an old X-ray. So again, if an old X-ray is available as an option, comparing that to the current film is always going to be the first step. If you see that the lesion is enlarging compared to a prior film, you should biopsy the lesion. However, you should be aware that if the lesion is really rapidly doubling, so doubling in size in less than 30 days, it's actually more likely to be an infectious etiology than a malignant. You have to keep in mind the particular clinical scenario to decide whether or not to biopsy the lesion. Here's an example of what a solitary pulmonary nodule may look like. You can see there's one isolated area of hyperdensity seen in the left upper lobe. When many of the features of a solitary pulmonary nodule are described under the malignant category, as listed on a previous slide, then you have to resect and remove the lesion. Sputum cytology, needle biopsy, and PET scanning should not be done first because a negative test is likely a false negative in that situation. So remember, if resection is one of the choices and the lesion has many features of being malignant, then that is the correct answer. Where the management of a solitary pulmonary nodule becomes more difficult is in the situation of an intermediate or gray area lesion. These have some inconclusive aspects with regard to whether they are benign or malignant. For example, a patient with an age range in that gap between 30 and 40. It's tough to decide whether they're more likely to be benign or malignant. Likewise, the size between 1 or 2 centimeters is also tough to figure out. So, we define these patients as intermediate probability. One way to start with these patients is sputum cytology. If it's positive, then this is highly specific, And then the most appropriate next step in management would be resection of the lesion. However, sputum cytology is often inconclusive. If it's negative, it does not exclude malignancy. Therefore, bronchoscopy or transthoracic needle biopsy are often needed to actually get a sample of the tumor itself. Each of these would be the most appropriate next step in most patients with intermediate probability of malignancy. If the lesion is located centrally, it can be accessed by bronchoscopy. If it's more peripheral, then transthoracic biopsy is necessary to get a sample. On step 2, for these patients with intermediate probability lesions, if you are given a diagnostic test question, for example, what is the next best test, then there must be a clear answer. In the situation where the choice of the test is not clear, the test question is actually going to focus more on the adverse effects of each different choice. One you should know is that the most common adverse effect of a transthoracic biopsy is a pneumothorax. Another way to manage intermediate probability lesions would be through positron emission tomography, or PET scan. This can tell you whether the content of the lesion is malignant without biopsying the lesion. Malignancy has increased uptake of tagged glucose. That's because these cells have higher metabolism than normal cells. Sensitivity of PET scan is about 85 to 95% sensitive. A negative scan therefore points away from malignancy. Another possibility is video-assisted thoracic surgery, or VATS. VATS is both more sensitive and more specific than all other forms of diagnostic testing for a solitary pulmonary nodule. You can gather a frozen section in the operating room, which allows for immediate conversion to an open thoracoscopy and lobectomy if the malignancy is found on pathology. One part of the differential diagnosis here is that a benign pulmonary nodule often represents scar from a previous infection. Sometimes on step 2, they might ask you about which infection you suspect. This depends on where the patient is from. For an immigrant, think tuberculosis. Old initial infection can resolve and can remain latent in the lung. Oftentimes this is only manifested by some scarring seen on film. If the patient is from the Southwest United States, think of the fungus coccidiomycosis. And if the patient is from the Ohio River Valley, think of the endemic fungus histoplasmosis. This concludes our part of the lecture regarding the management of a solitary pulmonary nodule. Interstitial lung disease is characterized by inflammation and/or fibrosis of the interalveolar septum. Rather than being a disease of the air spaces or alveoli, this is a disease of the septae, which is the tissue that surround all the alveoli. Fibrosis in the lung can cause impaired gas exchange, increased lung stiffness, and decreased lung compliance and expansion. This is a picture of a fibrosed lung. There is a very long list of different interstitial lung diseases, and it's also very difficult to keep the classification straight in your mind. For step 2, let's try to keep it simple. The most common and most commonly tested is idiopathic pulmonary fibrosis, and the other idiopathic interstitial pneumonias. Collagen vascular disease can also cause interstitial lung disease, granulomatous disorders, hypersensitivity disorders, pneumoconiosis, radiation, and drugs. The most common culprits you should be aware of for step 2 are the following: bleomycin, busulfan, amiodarone, methylsergide, nitrofurantoin, and cyclophosphamide. All of these different specific causes of interstitial lung disease will be touched upon briefly. Firstly, let's discuss the various pneumoconioses. These are diseases that are characterized by environmental exposures to certain heavy metals and other chemicals in the environment that can damage the lung and can cause an interstitial lung disease, eventually causing fibrosis. Let's talk about various environmental exposures and the types of lung diseases that they produce. Firstly, people exposed to coal over long periods of time, sometimes develop what we call coal workers' pneumoconiosis. People who do sandblasting or deal with a lot of rock mining or tunneling can come down with silicosis, too much exposure to silicone in the environment. Shipyard workers, pipe fitters, and insulators are often exposed to asbestos and can develop a pneumoconiosis called asbestosis. Importantly, this is a different disease process than mesothelioma, which can also be caused by asbestos exposure. Asbestosis simply refers to deposition of asbestos in the lungs, causing an interstitial lung disease. Patients exposed to cotton can develop bisonosis. Electric manufacturers develop berylliosis. And if you're exposed too long to moldy sugarcane, bagasosis can develop. The one you should be most familiar with for step 2 is berylliosis, and you should remember that the biopsy will show granulomas in a patient with berylliosis. In all forms of interstitial lung disease, there is some insult to the interstitium that causes ongoing inflammation. As with any other organ in the body, ongoing inflammation can finally result in the end stage, which is fibrosis. All forms of pulmonary fibrosis, regardless of etiology, will present with dyspnea, especially worsening on exertion, hypoxia, again much worse with exertion, and fine rales or crackles heard on the examination, sometimes described as Velcro-sounding crackles. Some patients will actually develop pulmonary hypertension over time, secondary to their interstitial lung disease. These patients will have a loud P2 sound heard on physical exam. If the hypoxia from their disease is long-standing, patients can develop clubbing of their fingers. Remember, inflammatory infiltration with white blood cells is reversible and treatable, often with immunosuppressant therapy. Once these diseases progress to the fibrosis stage, that degree of damage is essentially irreversible. For interstitial lung diseases, the answer to the best initial test is always a chest x-ray. However, chest x-rays have extremely poor accuracy with regard to interstitial lung disease. High-resolution CT scan is much more accurate than a chest x-ray. However, the most accurate test in this situation is a lung biopsy. In addition, these patients should often receive an echocardiogram. That's because if they develop pulmonary hypertension, you may see evidence of this and possibly of right ventricular hypertrophy on the echocardiogram. Here's an x-ray showing you some interstitial lung disease as seen on the plain film. Mostly, if you look out into the periphery of the lung, you see some area where there's fine reticular interstitial markings that are more pronounced than they should be. As you can tell, however, there is no way to see what sort of disease process is causing this just by a chest x-ray alone. A CT scan, on the other hand, can give you much better definition of the interstitial process that's going on. Here, we see severe, long-standing interstitial fibrosis that has actually resulted in thickening of the walls between the alveoli. This gives the classic appearance of honeycombing. In this situation, it's probably due to IPF, or interstitial pulmonary fibrosis. In this disease, we classically see worsening of the honeycombing in the periphery of the lungs. As you can see, the disease does appear worse in the periphery. All patients with interstitial lung disease should receive pulmonary function tests. Remember, a general rule of thumb is that in interstitial disease, all of the pulmonary function tests are going to have a proportional decrease in their values. The FEV1, the FVC, TLC, and RV are all decreased. That's because you have smaller, stiffer, and restricted lungs. But since everything is decreased, that FEV1 to FVC ratio will actually be normal. If you think back to our previous lecture, we remember that the FEV1 to FVC ratio was decreased in obstructive lung disease. In addition, the diffusion capacity is going to be decreased in proportion to the severity of the alveolar septal thickening. These patients have diffusion capacity restriction and they do not diffuse oxygen as well across their membranes as patients with normal lungs. This is responsible for a large degree of the hypoxia experienced by these patients. Unfortunately, most types of interstitial lung disease are untreatable. The biopsies will often show a white cell or inflammatory infiltrate. In that situation, prednisone can be helpful. If there's fibrosis mostly present, for example in an end-stage idiopathic pulmonary fibrosis, steroids will not be effective. Of all the causes of the pneumoconioses, borreliosis is the most likely to respond to steroids, and you should remember this fact for step 2. This is because, as we mentioned previously, borreliosis is associated with granuloma formation, and the granulomas can often respond to corticosteroids. Another commonly tested type of interstitial lung disease is a hypersensitivity pneumonitis. This is a specific type of interstitial lung disease caused by pulmonary hypersensitivity reaction to certain environmental antigens. It's basically an allergic reaction that's taking place within the lung parenchyma. Inflammation from hypersensitivity reactions eventually results in alveolar thickening and granuloma formation. The presentation of a hypersensitivity pneumonitis can either be acute or chronic. For the patient acutely exposed to the antigen, they may present with fever, dyspnea, and severe cough, often mimicking a bacterial pneumonia. This usually occurs very quickly, within 4 to 6 hours of antigen exposure. Some patients may be exposed to very low levels of the antigen over long periods of time. They may present more chronically. This is going to be progressive dyspnea on exertion with fine Velcro-sounding rales and pulmonary fibrosis. On step 2, you should be familiar with the most common antigens that cause hypersensitivity pneumonitis. These include antigens from feathers, which we call bird fancier's lung, MAI antigen, which we call hot tub lung, spores of actinomyces from moldy hay, also known as farmer's lung, spores of actinomyces from compost, which we call mushroom worker's lung, and spores of actinomyces from air conditioners, as you might guess, is called air conditioner lung. The treatment for hypersensitivity pneumonitis is quite simple. There's inflammation present, and like most allergic reactions, will respond very nicely to corticosteroids. In addition, we have to avoid ongoing exposure to the inciting agent. If the patient's not exposed to the allergen, this ongoing inflammation will not occur. This concludes our lecture on solitary pulmonary nodules and interstitial lung disease.